All right. Hello, and welcome to everyone who is joining us on today. I am very excited. I know I say that every time because I just always have good stuff and good people who join us so that we can talk about the things that you are truly interested in. And you guys know that right now I am interested in the weather, and the weather is doing the most right now. And one of the things that I want you guys to do is if you are watching and you are tuning in, let me know because I always want to recognize you because I am very much appreciative that you decided to take the time out. You can also let me know where you are watching from. You can let me know what the weather looks like because Savannah is flip flopping and we're kind of all over the place. But then we have this Arctic thing that's supposed to be coming in, and they actually said we might have snow. And I think the last time we had some kind of snow or snow flurries was around like 2018 or something. So
Woo.
just let me know what things are doing on your end. Dr. Sims, how are things going with, especially in regards to weather in Mississippi?
We are flip flopping as well. Last week it felt pretty good. Like 2 weeks before that, it was freezing cold. I mean, for here. Okay. First of all, let me just preface freezing cold with I'm from Wichita, Kansas, and I've also lived in Illinois. So freezing cold here is a little different than freezing cold anywhere else that I have lived. And so I have to say that. But then today, and yesterday it's gotten a little bit more chilly, it's gotten a little rainy, and I hear we supposed to get into like the low teens to the single digits probably this weekend. So we're gonna find out soon, I suppose.
Listen, the people in Savannah are like, what? Because I was talking to someone else. I was like, but that means I have to have a coat. Like, there's like we have like coats and jackets in Savannah, but not like a real coat, like a coat
Right.
coat. So, I
It's
don't
been a
think they're
while
gonna
since I
be
brought out like a real coat.
right. So I don't know if people are going to be out and about. I think Savannah is going to be really quiet because we're just like we don't do that here. That's just
Yeah.
not what we do.
This might be
Okay.
a good thing though to help to prevent like super spreaders of like the flu,
Yes.
which is like gone off the chains this year, and COVID. And so who knows, maybe the cold weather and the rain and the snow, maybe, it may be a blessing in disguise.
That's true. I see. Look at that. You look positive spin. I love it. Well, guys, we are not going to hold you much longer. I want to go ahead and get into this because this is a really good topic and it affects a lot of women and just people in general. So, this is lessons beyond the stethoscope. And, we provide practical tips and tools that you can use in your everyday life because we understand that this affects your overall health. Welcome to episode 8, Understanding Uterine Fibroids, Causes, Symptoms, and Treatment. And today we have joining us is Dr. Jaleen Sims. She is a practicing board certified obstetrician gynecologist at Jackson Hines Comprehensive Health Center in Jackson, Mississippi. And she's also the Associate Program Director for Wellness, Diversity, Equity, and Inclusion at the University of Mississippi Medical Center in the OBGYN residency program. She earned her Master's of Public Health and Medical degree at Southern Illinois University and completed her residency training in OBGYN at the University of Mississippi Medical Center. Now, outside of all of this, she has a passion for community outreach and she loves to serve the underserved. And so she is the founder and vice president of Sims Foundation of Hope Incorporated. And through her foundation, she hosts an annual conference called Imagine You. And it's for middle and high school girls, and it's aimed at promoting health and wellness, career and personal development, and positive images. So, as you can see, she is a very busy woman. But when she's not taking care of her patients and volunteering her time for her community, she enjoys spending lots of quality time with her family. So, thank you so much, Dr. Sims, for joining us on today.
Thank you so much for having me. I'm excited.
Good. Well, this is the thing. I recently read that uterine fibroids can affect up to 80% of women before they turn 50. Before the age of 50, 80% of women can be affected by this. And the symptoms that they have can be very debilitating. Like it can truly change lifestyles and what people are doing, their activities, and things of that nature. But there's hope because there are some different types of treatments that now are available that people may not recognize or know about. So I'm glad that you are here because now you can help us understand what are fibroids because people do not have to suffer from this. So let's just get right into it. What exactly? Let's just do the basics. I like to just start simple and start from the beginning. What are uterine fibroids? What are they?
Yeah, so uterine fibroids are, first of all, let me say they are benign. Because when you say tumor, sometimes it scares people like, oh, there's a tumor. But these are benign muscular tumors that grow from the uterine, like the muscular layer. Of course, they can be seen in multiple layers of the uterus, but they're benign muscular tumors that grow in the uterus.
Okay, and when
Very
she says
seldomly you'll
benign,
see that they're
oh,
cancerous.
gotcha, right. Because I know that's the thing. Because a lot of people are like, "Oh, are they cancerous?" And then some people say benign, and some people even like, "What's that?" So then
Right.
we just have to say non-cancerous. They are not cancerous. So I like
Right.
that you you said that because people truly need to understand that part of it. Now that we have and understand that it is this muscular growth, what are some of the symptoms that people can have from that because of it?
I would say the most common symptom is no symptom. Like some
Mm.
people, and that's how they have like that big range. Like when you read the literature, it'll say 40 to 80% of people have tumors or these benign muscular tumors, fibroids, or let me just get it down, fireballs, as I like to call them. And because of that big gap, or because they sometimes do not show symptoms, that's why you have that big range, because people don't know that they have them. But when people do experience symptoms, they may have heavy periods, they may have their regular periods, but then they bleed between their periods.
Mm.
Sometimes people bleed so significantly that they become anemic and even require a blood transfusion. Sometimes people have painful periods, and if they're extremely large, people have what we call bulk symptoms, and that is like bloating and abdominal pain. And depending on the location of them, they could cause for infertility.
Oh, okay. Now that we're thinking about a lot of these symptoms that you're talking about, like you said, they can have the heavy bleeding that can lead to anemia. With the anemia, people are really tired. With these symptoms, what are people coming to you saying, like, especially how does it affect their lifestyle and what they are trying to do? What do ladies or women come in and express to you?
Well, so sometimes the ones that actually come to me and say something like, I have to do something about these periods. They're really heavy.
Mm.
I sometimes have to wear diapers. I'm having to stay home when I'm on my period. I don't want to wear white. I don't want to go out of the house much because I'm having to change my pad or my pad and tampon every 30 minutes, every hour. And I'm just
Mm.
afraid that I'm going to bleed through my clothes. Sometimes they'll say, well, my period is just kind of normal, but I'm passing these big golf ball sized blood clots.
Mm.
Like, and it hurts. I can always tell when I pass it because it hurts. Like I have cramping pain with it. So those are the most common things that people say to me when they come to me with like abnormal, what we call abnormal uterine bleeding. But here's the other caveat. Sometimes I'll ask people about their periods and they'll say, oh, they're normal. And I'm like, okay, great. So how often they last? Oh, well, they last about 10 days. And I'm like, wait a
Mm.
minute, 10 days? Tell me more. And so they think, oh, well, this is normal because this is how it's always been. But people have to realize that normal is normal. And then you have what you got going on. Passing blood
Right.
clots is not normal.
Right. And I like that you're saying that because and that is so true because everyone has their different barometer of what's normal. So if that's always happened to you, like, oh yeah, that's normal, you're like, no, that's an issue.
Hmm.
Yeah.
Exactly. Or they'll present and they're really fatigued, but they have no connection with their period. And we're like, okay, well, let's get a blood count, let's get thyroid hormone. And by the way, your blood count is really low. How are your periods? And they're like, oh, well, I mean, I bleed. And it's like, they don't really put two and two together. And so you have to kind of piece it together for them. Like, wait a minute, girl, your periods are heavy. How often are you changing your pad? Well, like, every hour, every 30 minutes sometimes. I'm like, child, okay, let's fix this. Let's do something about this.
That's true. And I can only imagine, because I remember you touched on it earlier, that some people are having to miss work. They're having to, determine what kind of wardrobe they're gonna wear. Some people
Mhm.
are like, oh, that's not the big deal, but that's changing. Like I can't wear certain things because of this. There are
Mhm.
accidents, some people will admit and say it, but that's the reason why some ladies are wearing the diapers and stuff like that. So it
Right.
changes that. I can only imagine some of the psychological things that are happening with this process. And with that, I wanted to touch on, because I know that you had mentioned earlier, because we kind of talked about this, but families, how this whole system and everything that's going on affect families.
You know, um, that is pretty significant. Like, some people don't realize the things that happen with the family. So, number one, when you have to take off work because you're bleeding so heavily or your periods are so painful, well, that decreases the income that you have for your family. So now your finances are impacted. If you have prolonged bleeding and you are unable to be intimate with your mate, well, that affects your relationship. If you and your partner are looking to have a baby, and the fibroids are in a a location that would prevent implantation of, an embryo, well, it causes, fertility issues. And so there's so many things. And then you mentioned the psychological aspect. If I'm in pain and I'm bleeding heavily all the time, it's going to cause me to feel a little bit down, or I'm going to feel anxious because I'm like, okay, I'm always checking for, do I see blood spots, things like that when I'm out and about. And so for the people that already have anxiety, depression, or any other mental health disorder, it could totally worsen those things. And so it's a whole spectrum of things that you can see, and how it impacts the family and how it impacts, the person. And say, for instance, the mom who is having this issue. Well, she may not be able to be interactive with her children while she's in a lot of pain.
Mhm.
She may not be able to take her children to the park the way that she would want to. She's going to miss out on family activities. And so, I mean, it literally impacts the entire family.
That's good. And I want to, because I sometimes people do not understand how this is going on with me can also affect, everything else that is connected
Mhm.
to us. I really appreciate you being able to kind of dissect that out and show that to us. But with that, we know that we have these symptoms. Who is actually at risk? Like, what are my risk factors for even being to have to develop these fibroids?
Right. So, genetics, of course, that's something we can't change,
Right.
unfortunately. A family history, if you have family members, like, sometimes I'll talk to patients and they'll say, oh, yeah, my mom had a hysterectomy for fibroids. Her mom had a hysterectomy for fibroids. Her sisters had a hysterectomy for fibroids. And now here I am with heavy menstrual bleeding. Can you check and just see if I have fibroids? And so there is a family history component. Now, let's go to the other side. Anything that can lead to prolonged exposure of estrogen. So, what do I mean by that? A person that starts her period earlier in life, prior to like the average. So, like, say a person that starts her period at 9 or 10 years old compared to the person that starts her period at 13 years old. A person that went through menopause late, which means that she'll continue to have
Mm.
estrogen for an extended period of time. A person who had their first baby in her later years. And now let me tell you something about this. That's why I don't like that term, advanced maternal age, or what is it? Um, the old mama, whatever you call it. There's like an actual term for it. And I'm like, because people are now doing their careers first, and
Right.
you're seeing that they're having babies a little later. And
Right.
so I hate that like put you at risk for these dirty old fibrils. But yes, that and then here's the other part, obesity. Why
Mm.
would obesity be a part of it? Well, so fat cells or adipose tissue, it actually makes estrogen. So the
Mhm.
more fat cells that we have on our bodies, the more estrogen we have in our system. So as a result, that can increase our risk for fibroids.
Yeah. Oh, this is so good. I'm with you on that whole advanced maternal age. I understand that's a whole nother topic you're gonna have to come back and talk to us on because I'm with you on that. But outside of that, we know who's at risk. We know about our symptoms. Is there anything that people can do to try to decrease their symptoms, if that makes sense? Is there anything
Yes.
that we can do? Is there like, I know that there's treatments, but is there anything that they can avoid to kind of decrease their symptoms themselves before they go to the treatment stage?
So one of the things that I was actually kind of reading about this last night just to make sure that I kind of had the loose ends tied up on it. And, you know, we cannot change our genetics, unfortunately.
Right.
Sometimes we might want to change something, but we don't have the pleasure of being able to change our family history and things like that. And so as a result, we have to look at like our lifestyle modifications. And so making sure that we are exercising. So of course the World Health Organization recommends 150 minutes of
Mhm.
exercise every week. So that comes out to be about 30 minutes 5 days a week. And of course, if you're looking to lose weight, sometimes you may have to do a little bit more. And then your diet, eating things that would be conducive to you having a healthy lifestyle, things that are conducive to you keeping a good weight on your body. Now, I say this to my patients all the time. Like I mentioned the 150 minutes, and sometimes that really discourages people because they don't have
Mm.
time. I back that up by saying, do what you can.
Yeah.
If you're unable to exercise for 150 minutes in a week, it's better to do 30 minutes than nothing. So, there's going to be times where you can do more than 150 minutes, and there's going to be times where you're like, I can barely get to 30 minutes this week.
Mhm.
So, it all adds up. Just do what you can as far as your exercise. And then the one thing that you know that you can do for the most part is you can meal prep. You can meal prep healthy foods with being well balanced, and you can meal prep to the point where you bring your lunch. You can to work, so you don't have to go eat out. And a lot of times when we eat out, we just eat unhealthy foods, a lot of starchy
Mhm.
foods and things like that. And those foods would be contributing factors to increasing like our fat cells.
I like that you gave the tips and stuff as well because you're right, and I'm with you on that whole do what you can, at least do something.
Mhm.
And I even tell my patients, I said, listen, I'm not saying that you have to go and join CrossFit, right? Like we don't have to do, and that's not everybody's thing. Everybody's not into CrossFit. Do what you can, do what you like to do. I said, let's just do a 30-minute walk. Now, I
Mhm.
tell them when you go and do that 30-minute walk, though, I don't want it to be like you're on the phone because I see some ladies walking around my park and they are on the phone and they're like, yeah, girl, and then yeah. And I'm like, no, like this is when you're on the phone. And if you're trying to have a conversation with somebody on the phone, they're like, girl, call me back, like when you finish, because because you want to get your heart rate and stuff up and you really want to get moving where you can't
Exactly.
have that, those sentences and stuff like that. But I appreciate you saying that. Do what you can, get out, get active, try to be intentional about some of those things because that's one of the things that we talk about a lot is intention. So being
Right.
intentional about, this is what I want to do, and then how can I take the steps to get it done. But so now that we have talked about these are some things that we can do on our end. I've made some of those adjustments. I'm still not seeing the results and I'm still having a lot of these symptoms. I go to my doctor and like, hey doc, like what can we do to get this under control? I know that you mentioned hysterectomy, but there are also some other treatment
Yeah.
options out there. Talk to us about that.
So, um, when a person comes and they say, okay, number one, I have heavy periods, and you get your evaluation, you're going to have a pap smear, you're going to have a
Mhm.
pelvic exam, and you'll have a transvaginal ultrasound. Those are the most common ways that we can actually diagnose, okay, what's going on? Okay, at this point, we have confirmed that you do have fibroids. And some people say, well, now I know what's going on. I don't want to do anything. I'm just going to kind of watch it for now. So, surveillance, I want to make sure people realize, is an option. You do not have to pick an active form of management. You can just say, we'll just watch it. And next year, we'll come back. We'll do my pelvic exam for my annual exam. And we'll see if my symptoms are changing. So, I just want to throw that out there. There is medical therapy. As a part of the medical therapy, it doesn't have to be hormone based. You can actually be on NSAIDs like ibuprofen or Aleve, naproxen, things like that, because that can help with the pain. And theoretically, it's supposed to decrease the blood flow from your periods. Now, if you are bleeding extremely heavy, I would not think that NSAIDs would be, something that would just give you a significant improvement in your symptoms. But if it's like, it's slightly manageable, then that might be a good option for you. So that's the non-hormonal option. Then you also have like your birth control versus non-birth control options, but they are still hormonal. And so there's like progesterone only options. Say you're not a great candidate for estrogen therapy. So there's progesterone only options, which typically most people are. And then there's also like some really, really big gun options, Depo-Lupron. So now y'all heard me say Depo. We're not talking about the Depo shot. We talking about Depo-Lupron. It basically blocks your hormones at the brain level and puts you almost like you're in menopause. And from there, people do really well as it relates to like their periods are concerned, but then they hot flashing. And so but there's like a spectra of medical options. Then you go into your surgery options because you want to try medicine before you try surgery, unless your fibroids. The largest fibroid that I have removed was about 20 centimeters. Y'all, that's the size of a newborn baby, a good size newborn baby. Okay. A term newborn baby. And so for that person, she might be ready for a hysterectomy, but there is a myomectomy, meaning we remove the fibroids. There are endometrial ablations. So say your periods are heavy, they're a little long, but your uterus is not like significantly enlarged and you just want to slow down your periods or be in a position where there's possibility that you won't have periods anymore, you can do what we call an endometrial ablation, where we burn the lining of the uterus. And there's also some radio frequency treatments and things like that. I don't do that personally, but I have a friend that does. And I hear that there's some good results from that. I'm actually interested in learning more about that. There's also one other option. So for the person that doesn't want to be out for an extended period of time, they don't have any future fertility goals, like say they've gotten their tubes tied, they don't want any more children. A uterine artery embolization is actually an option. They would go to the interventional radiologist and they would just basically clot off or embolize the blood vessels that are going to the fibroids. And it's supposed to significantly decrease the blood flow from the menstrual cycle. And I do have patients that do that as well.
So there are like so many options. There are a lot.
It's so important for people to know that, because I've had so many patients come to me and say, well, I was told I have to have a hysterectomy. And I'm like, first of all, no, that's not the case. Tell me a little bit more about your fertility goals. Tell me more about what your symptoms are. And from there, I'm going to tell you your options. And I want you to tell me what you feel like would be best for you. Now, there are certain times where I feel strongly about something, but otherwise, like if it's not anything significant where like the person's bleeding down to a blood count of 5 or something like that, you're supposed to use shared decision-making with your provider. Like the person that comes to you and says that your only option is a hysterectomy, I say run, and I say run fast.
Yeah. I appreciate you saying that, because I've had several people come to me and they're like, and the other thing too is it's like where you're talking about with the genetics. My mom had one, my cousin had one, my aunt had one. So then you may not have even heard it from anyone else, but that's your expectation because everyone else had it. and that's what they did. So I think now that I'm next in line, I guess that's my option. That's what I'm supposed to do. So I
Right.
appreciate you saying no. We have a lot of other different options. There are a lot of other things that can happen, unless, like you said, there are certain situations where this might just be the thing. But just looking at everything and looking at the full picture, I appreciate that. One of the big questions that I get a lot though from patients before I send them, to OB for evaluation, is those who are going to have a hysterectomy. The question they have is like, what are some of the things that I'm going to have to experience afterwards? I've heard that there's going to be urinary incontinence and I may wet myself, or I'm not going to be able to hold my muscles tight in my stomach, or like all these different things that people have heard or heard from other people, or whatever the issue may be. Can you touch on that a little bit for me?
So, it's kind of complex, and it's a little bit
Yeah,
more than just having a hysterectomy. So
right.
your pelvic floor actually is what supports your bladder and like your rectum and things like that. And there are some areas of support that your uterus provides. So yes, there may be a little bit, but typically, when there's a provider that performs, like say the person has an large uterus and they get an open hysterectomy, um, there's things that we can do if we're concerned that, you may have what we call pelvic organ prolapse.
Mm,
And typically, when people have dropped bladder or pelvic organ prolapse, they may leak a little bit. One of the things that I have found is that sometimes people say it happened after they had their hysterectomy, but when they really get questioned and think back about it, it was happening prior to the hysterectomy too.
mm. Okay.
And so, like the stress incontinence, meaning like you laugh, you cough, you sneeze, and you leak a little bit from the bladder, or the person that's always having to wear a pad or a panty liner because they just want to make sure that they don't leak. There's also even a component of what we call urge incontinence, meaning you feel the need, you feel the urge to go to the restroom, and it's like, oh shoot, I can't make it there, or overactive bladder. So it's a little bit more complex than just I had a hysterectomy and as a result I have these symptoms. Now, one of the things I do want to touch on is some people say after I've had a hysterectomy, sex isn't the same.
Mm,
I want to throw that out there
yeah.
because I have a lot of patients that are like, let me tell you, I'm not bleeding anymore. I'm happy. Like, sex is great. My relationship is great.
Mm,
What I would recommend is to express your concerns to your provider, because I have seen where people that have had hysterectomies, their vagina is left very, very short. And as a result, sex is difficult with a short vagina. And so there are ways that we can close the vagina to like make sure that it remains long. Now, if the person is already a small person and already has a short vagina, we don't want to like cut back on how much we use to close the vagina, because we don't want them to have what we call a dehiscence, meaning that area opening up and not healing properly.
mm.
But we can make sure that we leave you with enough in order to enjoy yourselves with your partners,
That
and
is
still,
so
get
good.
good lubrication as well.
Yeah. Okay. I appreciate that because not a lot of people will talk about it, and again, they're suffering and like, oh, maybe I shouldn't say that, or they feel shame or whatever
Mhm,
is associated with it. So I really really appreciate you bringing that piece out, because like you said, again, this goes back to I have something going on, but it affects everybody else. So that's going to affect your relationship and how
mhm.
you are with your partner, things of that nature. So that's crucial. I mean, we've talked about so much and realized just how much this can affect others. Are there any other like comments that you would like to make about it, or leave us with any other information?
So, I want to just make sure that when you are planning to go see your gynecologist, that your concerns are addressed. So, how can you advocate for yourself? Number one, write down your concerns before your visit. That way, when you go, you can say, look, I have a list of things that I would like for us to cover during this visit related to my fibroids. Now, let me tell you, it is difficult when you come in when a patient comes in and has the list of questions about the fibroid, but then they want to talk about like their back pain or their, headaches, and then like a lot of other different things, because it actually dilutes the visit. And as a result, you may leave and say, well, I got nothing out of that visit. So if you can just focus in on what your concerns are about your hysterectomy or about your fibroids, write down those questions. That way, when you go and you're sitting before the provider, you don't forget what it is that you need to say or ask. So I say that to say, I would like for you to advocate for yourself. Number 2, don't be ashamed to ask questions. I've had so many people say to me, well, I've had people tell me this or that, and they're like, oh, not, and I'm like, just say it. Just say, like, just tell me what it is that you're concerned about, because I want to help you. And that's when I get well, I heard sex isn't the same. I heard sex like is, that's typically how I get that. Like, well, I've
Mm-hmm.
had friends to say that, and they're like beating around the bush.
Yep.
Just be direct, because if your concerns are not addressed, then you're
Mm-hmm.
still going to be afraid. And then you're going to have to find out post-operatively what it really is on your own, when you
Mm-hmm.
can have your provider just kind of explain to you what their plans are to make sure that, they leave your vagina in one piece and things like that. And then the other thing is, make sure that you feel a part of the decision. And that's the
Mm-hmm.
reason why I said shared decision making. You should feel like you are satisfied with the decision that was made when you leave the office. If you feel like you were forced into something, or if you feel that there was only one option available, it's okay to get a second opinion. It's okay
Mm-hmm.
to grab your records and take them to another provider. And it's nothing against that person. It's just a matter of who you feel like you would mesh well with. So this is a day and age where the paternalism, and as it relates to, healthcare, it's out the door. Like, you have to do what you know is best for you and your family. And that's the reason why I thought that the question related to how does this affect your family, you know, um, that was so relevant, because one surgical option can take you off of work for a
Mm-hmm.
whole 6 weeks. And if that's the only thing that is offered to you, when you know that there are other options for your particular situation, then, and that'll only take you off for a couple of days, then, like I said, like, we as providers, we don't know your home situation like you do. And as a result, you have to protect your peace and protect your home situation, protect your family.
Oh, this is so good, Dr. Sims. Listen, I and she and I did not discuss this, but we are on the same wavelength. You guys know that I am big on advocacy. I am big on finding the provider that makes the most sense for you, because
Mhm.
in this day and age, like she said, we have options. So it's not against that person. Maybe that just is not a good fit, and that's okay. And so you respectfully say, "Can I have my records?" and then go somewhere that makes the most sense for you. But all of those are such good points, and I'm so glad that you said that, because these are important decisions, life changing decisions that
Mhm.
you could potentially be making, and you want to make sure that you feel comfortable while you are making that decision. So
Mhm.
thank you so much, Dr. Sims, for joining us today and just giving us all this good information. I really do appreciate it, and I learned something myself today, so thank you.
I'm so excited that you had me come and speak with you today. This was great.
Awesome. Well, guys, I hope that you found that this was very helpful. If you know someone who is suffering, if you know that this is something that potentially occurs in your family, or you know other people, I mean, honestly, we said up to 80%. So that's a lot of
Mhm.
women that you can
Yeah.
with. And we know a lot of families, a lot of people can definitely benefit from this information. So be sure to share it, put the information out there so they will know. Let us know what you thought about it, so that we can, say, okay, yeah, maybe we need to put some more information about this, because people do still have questions about it. I will also tag and try to put that information out there, because I did a video, and I have a sheet that helps you to organize. Like she said, when you go to your doctor's visit, you can't be all over the place, because
Yeah.
we are like, what? Huh? Like, we're trying to figure out exactly what you really want us to focus on. So if you are truly concerned about this thing, I have that worksheet where you can list out your concerns and say, this is what I really want to talk about, so that you can get the answers and everything that you need. So I'll try to link it, figure out how to do that, but I'll link that. I'll also link the video where I talk about it some more in detail, so you'll know how to be prepared for your doctor's visit, because I have 6 great tips on how to do that, so that you can get what you need, so that you can advocate for yourself. But guys, thank you so much for your time. I know we'll see Dr. Sims again, because she was awesome today, and we're going to get some more great information out of her in the future. But until then, and until next time, take care, and we will see you soon.
Bye.